Rachel's asked me to share a bit of my story as well, just really to emphasise the importance of patient choice and also the importance of supported decision making. I've started to say supported decision making instead of shared. I think we need to put the patient back in the centre of this, the right to autonomy and self-determination now. So very, very briefly, I know I've not got a lot of time. My son was born with cerebral palsy following a very traumatic delivery. And this was 21 years ago now, he's 21. The background to the story is I was type 1 diabetic, I had a lot of risk factors, I was high risk, and my baby was growing to a very, very large, gaining weight rapidly and getting, the diabetic babies basically put on weight in their shoulders and they look like little sumo wrestlers when they come out. So I could see from the centile chart in the antenatal period that he was growing very large, and he reached the 95th centile. And I raised my concerns repeatedly with my consultant, particularly about my ability to deliver the baby of this size, but also because I'm only 5 foot tall, and I had lots of concerns. But my concerns were never addressed. They were never discussed. I was always met with, "Don't worry, we're looking after you, leave it to us," you know, that kind of thing. I took my mum, who was a GP, with me once. I thought maybe she would be able to get some sort of conversations going, but no. Again, it was like, "Don't worry, we're looking after her, leave it to us." But still no questions were answered. I was brought in for induction at 38 weeks. I entered into a lengthy labour. It needed augmentation with oxytocin. And the following evening, due to failure to progress, I was taken to theatre for what was called a trial of forceps. Still at this point, no risks had been discussed with me, and I had no real understanding of the procedure or any potential complications that could arise. In theatre, they attempted to deliver Sam using rotational, my son's called Sam, sorry, I should have said that, using rotational forceps, and I had no idea of the complications unfolding. I just really felt a lot of pulling and a lot of time elapsing, and eventually the anaesthetist came over to me and just very gently told me, "We're going to put you to sleep." And I think at that point I knew something was seriously wrong. So I woke up, you know, many hours later in a lot of pain and drifting in and out of consciousness. I was told I had a baby boy who was very, very sick. He was in a special care baby unit. The nurses were fantastic, brought me Polaroid pictures and kept me up to date. And it was a horrible, you can all remember the moment you see your first child, you know, you're happy. But this was happiness, but also complete shock and devastation. What had happened? He was ventilated with tubes and it was awful. But it was only really in the coming days that I found out what happened in theatre. And what happened in theatre was they delivered Sam's head using rotational forceps, but his shoulders became stuck. I later found out that's a phenomenon called shoulder dystocia, and he was stuck for a period of 12 minutes. They attempted several last resorts to deliver him, including breaking his clavicles, attempts to break them, to fold the shoulders in, to pull them out, that weren't successful. They attempted to push his head back inside. I have no doubt during that manoeuvre that more damage was sustained to the fetal head at that time. That was unsuccessful, and finally they made 2 attempts to break my pelvic bone or cartilage in the hope that that would open up my hips and allow him to be delivered. My consultant said that it gave her a little bit of leeway, and with one final surge of adrenaline, she pulled so hard in his left arm she managed to free him. He was obviously born stillborn. He required CPR and adrenaline to restore his heartbeat, and it was just shocking. And he spent a very difficult 6 weeks in special care baby unit. He had his lungs ventilated, suffered with seizures due to hypoxic encephalopathy. He had trauma to his head, face, neck, forceps scars with subdural hematomas. He was diagnosed immediately with a left side Erb's palsy, which is a sort of paralysis of the left arm. The nerves are severed or damaged. And at 3 months of age, he was diagnosed with cerebral palsy. So obviously, after the events, after I'd recovered, I took a long recovery myself. We wanted to know, you know, could this have been predicted or prevented? I was given a very basic explanation from my consultant. And what we discovered looking through GMC guidelines, obstetric college guidelines, was that as a type 1 diabetic, I had a 9 to 10% chance of this phenomenon called shoulder dystocia. And I was absolutely furious that this hadn't been discussed with me. On top of that, other risk factors were use of instrumental delivery, such as the forceps, use of oxytocin, short stature, known large baby, by the time I got to theatre, I think I had every single risk factor. So this hadn't been discussed, and I was absolutely angry. So we composed a complaint letter, and the usual complaint letter that, you know, goes and you're met with the crappy response of, we're sorry for your sad outcome. We've conducted our own, investigation into it, and we're happy that, your care was adequate. And I think anyone who's been through a tragedy, I'm sure there's lots of people here, and maybe James understands, you were not wanting, what we want is for someone to acknowledge what has happened. We would like an apology, which would be great, but we also want implementation as to what's going to happen to make sure this doesn't happen again. More than anything, this isn't about a financial settlement. This is about what are you going to do to make sure this doesn't happen again. And if no one, cared or recognised that there's a deficiency in my care, then that was my main concern, that no positive changes would be made, and therefore it would happen again to someone else. So it became my goal to ensure that, others didn't go through what I went through, and the right discussions should be taking place between doctors and patients. So we journeyed all the way to the Supreme Court, and we were unsuccessful in both the Scottish courts, inner house and outer house. And in 2014, we went to the Supreme Court, and they assembled a bench of 7 judges, and that gave us some sort of insight into how seriously they were taking this. And that was great, because I thought, even if we're not successful at this stage, somebody's listening and we're highlighting this matter. The GMC also intervened on my behalf, highlighting the good medical practice guidelines from the era of Sam's birth, which was 1999, and that doctors and patients should be making their decisions together. So a year later, in 2015, all 7 judges unanimously agreed. And the ethical guidance with respect to informed consent, that actually was already essential for doctors. Good doctors were doing that anyway, but that was then passed into law. And Lord Reid said, "The doctor is therefore under a duty to take reasonable care to ensure that the patient is aware of any material risks involved in any treatment, recommended treatment, and of any reasonable alternative." Basically putting the onus firmly, the decisions firmly back in the hands of the patient. And they added, with the advent of the Human Rights Act, patients are now viewed as persons holding rights, not just the passive recipients of the care of the medical profession. We have support groups and all sorts of things that have brought us into, 2020 now. And so I hope that highlights the importance of making decisions together, and what can go wrong when that decision is taken away. Because when that decision was made for me, I live with the consequences of that, not the doctor. I mean, I've never seen that doctor again, and probably never will. And she's probably never even thought about us again, but we live with the consequences of her decision. So I think as well, finally, paternalism for too long has been the dominant model for the relationship between doctor and patient, with the idea that it somehow serves the patient's best interest because we're not quite capable of making decisions ourselves. We're not smart enough. And I think in my case in Montgomery, we took that back and we said we are capable of making decisions, but we need the support of our healthcare professionals to do that. So I hope that's helpful, and thank you very much for having me.
Nadine, thank you so much. That's fantastically helpful, and it's such an incredible story, both in terms of the information that you weren't given to make that informed decision, but also the fight that you've had and taking your case right to the top of the judiciary. I mean, it's a huge amount of work, at the same time as, I know, bringing up your son and making sure that he's had the very best support to achieve, as I know he has. So thank you so much. But it's and I think it's such an important story as well, in terms of, for anybody, whether you're having treatment for surgery, or whether you're making a decision about having chemotherapy or drugs you might be starting for your rheumatoid arthritis, whatever it is. Actually, we all want to have all the information to weigh up the risks and balances for our lives and what's important to us in our lives. So important. There's one question I'm just going to, before I go on to James, that someone has asked, which Brian Finney has asked if you could explain, if Nadine could explain the difference between supported decision making compared to shared decision making. So I think it would just.
Do you want me to explain that now? Yes. This is what I think. This is not necessarily correct, or this is just my viewpoint. I think we need to, when we say shared decision making, we're talking about we're sharing the decision, aren't we? But no, I think what I firmly believe is that decision is firmly placed in the hands of the patient. The patient is the one that makes that decision. So the role of the healthcare professional is to explain the risks, all the reasonable options, the risks, the benefits, and you talk about them together, and we tailor that consent to each person, because each person comes with their own unique set of circumstances, so that has to be tailored to them. And then the patient makes that decision, and that's why I think it should be supported and not shared. I hope I'm not very good at explaining myself, but I hope that's...
No, I think that's really clear. And there are quite a few messages here from people saying, thanking you, Nadine, saying that what you've just said was really moving and respecting your resilience to fight for others. And thanking you so much for sharing. So I'm now, so that's, we'll come back to everybody because we'll be answering more questions and having a discussion, but I want to come on to James. James, thank you so much for joining us and coming to tell us again about Joshua's story and why patients in partnership matters to you. Thank you.
It's just amazing. I've got so much respect for Nadine and what a difference that story's made to maternity. It literally has changed.
James,
I think about consent. Oh, hello?
can you talk a little bit louder because we can't hear you?
I can. Can you hear me now?
Is that better for people?
Is that better? Can people hear me?
A bit louder.
Oh, I'll have to come really close and shout. Can you hear me now? I guess my microphone might not be too good, so I'll assume everybody can hear me.
That's fine, James. Carry on.
Fantastic. Okay, so yeah, I'll talk a little bit about my story then and about Joshua. So my background's nothing to do with healthcare. I graduated in engineering and I worked in the nuclear industry. In 2008, we had a terrible family tragedy, and I'll just talk to you briefly about that because that changed my life, and from that moment I became involved in various different ways with patient safety. So the story starts in 2008. My wife had a normal pregnancy, very healthy, and we were expecting a new baby boy in time for Christmas 2008. And about 4 weeks before Joshua was due, we had a week where we'd been feeling very poorly with headaches and sore throats. And the weekend came, and on the Saturday night, my wife's waters broke. And this was very early, so we were worried. Went to the hospital, got checked over, got sent home again, told to look out for various signs. And that carried on for kind of the next 2 days. And then Joshua was born, and shortly after Joshua was born, my wife collapsed, and she was given fluids and antibiotics and recovered. But of course, we were concerned about Joshua, and we asked, is he okay? And we were reassured, yeah, Joshua's fine, there's no problem with him. But he actually had many signs of being a very unwell baby. And very sadly, he collapsed 24 hours. He collapsed an overwhelming infection. And from that moment on, he had a desperate struggle to survive. He was transferred to Manchester and then later transferred to Freeman Hospital in Newcastle, where he was given world-class care. But unfortunately, the damage to Joshua from that untreated infection was so much that on the 9th day of his life, he began to bleed from his lungs that were very damaged, and that bleeding got worse and worse. And on the 5th of November 2008, they had to turn Joshua's life support machine off, and Joshua died. But really, it's what happened next that's shaped my involvement in patient safety. Coming from a very safety critical industry like the nuclear industry, my expectation was that the way the healthcare system would respond would be to not leave any stone unturned. But actually, we faced, similar to Nadine when she was looking for answers, this incredibly defensive system. So there was no inquest, there was a very poor investigation, and really it took perhaps 6 or 7 years of campaigning, eventually getting an inquiry, before we got to the truth really about what happened to Joshua and about the learning. So we've talked today about patient partnership and engagement, and I think my message would be my experience after Joshua died as a harmed patient perhaps is the very opposite of partnership, that word partnership. I can't imagine an approach that would be more opposite to what partnership would look like. So I'm really encouraged by this strategy. I think it's hugely important, and the bit of it I think that I'm particularly passionate about is how the healthcare system treats and responds to families and patients after there has been harm. And I think that word partnership is a really great way of looking at it, because that's what it should be. It should be the healthcare system with the harm patient and their family working together, because they do want the same thing. They want to understand what happened and why. They want to understand what changes are going to be made. They want to be part of that process so that they can help with implementation, to make sure things happen. And at the moment, we don't have a very good system. I would say the system at the moment does the opposite of that. So I think, my own perspective is the importance of treating harm patients and families as partners and finding new ways of working, a restorative approach rather than this very defensive approach. And I'd be very interested in having a conversation this afternoon about that. Yeah.
James, thank you so much. And your story reiterates, as you said, what Nadine said. And actually, you've reminded me that I should have said that I think you were part of a new charity that started called the Harm Patients Alliance. So we haven't yet had a chance to work in partnership with you, but I know that we will be really wanting to do that, because
not a charity yet, but it's a campaign, and I'm working with an amazing, I have to mention Joanne Hughes,
yes,
an amazing mother who many of you will know. But she's really been the inspiration for that work. But yeah, it's all about how to partner with harm patients and improving that restorative approach to healing after harm.
Thank you.
Could I suggest that you turn off your camera maybe, because I think you're getting storms and your voice is coming in and out, and some of the panelists, some of the audience are finding it hard to hear you.
Oh, I'm very sorry about that.
No,
that's much better.
Much better. Thank you so much. We'll try and get you back on, because it's nice to see your face as well.
No, it's better without my face. But I think I need to invest in new technology, Rachel. My laptop's letting me down.
No, James, you were absolutely fine when we met before. So I think it's the storms that are hitting everywhere has caused your Wi-Fi to go weak.
Yeah, I think it's, but anyway, but thank you so much, James. And I think that's one of the things that is so concerning, is that is the way the NHS responds when people raise concerns. That it's extraordinary that people still find it difficult to say I'm sorry, and to then work with us all as partners to find out, to understand what's gone wrong, and use what you've got to share to help them really find those answers. So that's a really good lead into our third panelist, Suzanne, to tell us about your experiences, from the experience of your experiences as a clinical negligence lawyer, Suzanne.
Hi, and can you hear me? Yeah, you can hear me. Thank you very much indeed. And thank you for inviting me to be on the panel. I'm hugely honoured to be in the company of such inspiring patient campaigners such as Nadine and James. In fact, it's I always dread coming after them, because they are such brilliant speakers and very, very inspiring people. So I'm also honoured to be here as the trustee of the Patient Association, the work of which I have admired over many years. And the focus today is on patient partnership and the importance of health equality and fairness. So just to give you a bit of background for me, I have a medical background. I initially trained as a radiographer and worked as a radiographer whilst I was studying law. So I therefore do have a perspective from the healthcare professional's viewpoint. I worked and trained at King's College, which is a very busy teaching hospital, and it's a real life experience. And certainly things have changed since those days. I felt there was very much a more paternalistic approach to patients, not so much of a partnership or a shared decision-making approach, but much more of a doctor knows best attitude. I also worked as a radiographer in the private sector as well as the NHS, so I did see how patients were treated in the private sector and the NHS, and there were actually some very stark differences. And from my perspective, private care does not always mean best care. Choice, rights, equality and fairness must always be the basis for patient partnership. And as a lawyer, I still see inequality in patients' rights. Some of this may be for political reasons, such as shortage of staff and funding and resources and services. But this is no excuse for providing poor care and making sure that patients is part of the decision-making process. So a patient partnership should involve and will involve choice and a good consent process. And in my view, that drive good care and good outcomes for patients. I do think certainly things are improving and have improved since Nadine won her brilliant and brave case. And she really, really must take credit for that, because as a lawyer fighting for years on appeals and to going to the Supreme Court must have been the most stressful thing to endure. And she is an amazingly brave young woman. It has transformed patient choice and in my view is massively driven better care and informed consent. And certainly in my practice, I have seen this happen. It is good for the medical profession and it is good for the patient. However, we have some way to go with improving patient care and the patient partnership, in my view. And particularly in relation to maternity care, there really has been nothing less than a tragedy for many families in maternity scandals this year. And just yesterday, Nottingham NHS Trust was in the news. Also in the news this year has been in East Kent, Shrewsbury, Wales, and of course we've got Jeremy Hunt's inquiry into the safety of maternity care all this year. So I do think we have a long way to go, because this is not historical, this is happening now. Certainly in the light of COVID, things have become very challenging with the delay in routine care and follow-up and long waiting lists. These are very difficult times and ripe for us to focus on improving the patient partnership. So I very much look forward to helping the Patient Association with this and partners and Nadine and James, and I'm very much looking forward to a discussion. Thank you.
Thank you very much, Suzanne. That's really helpful and actually was one of the first questions I was going to ask people just to start some of our discussion. And I think we have was really about how far people think they've come. And I should probably, I also come from a background in having worked in the health service, and I would absolutely agree with you that over my career, we've moved from a doctor knows best, and in fact more than doctors knows best, probably to at a time I started my training when people often didn't necessarily know what was happening to them. So we have moved an awful long way, but it's still patchy and inconsistent. And I always talk about people who doctors who I regard as normal people who talk to you normally and value you and listen to you, and people who, I'm small like you, Nadine, I'm only 5 foot, so people who pat you on the head metaphorically and say, don't worry your pretty little head about that. So there is still a huge journey to go, as you say, Suzanne. So I'm really interested just to start the conversation by asking people, and perhaps if I start with Nadine, to ask the panel about how far do you think the NHS has got on this journey, and have you seen any sort of examples of good practice in the work you've been doing? Nadine.
In partnership specifically, I think we have definitely come a long way. Do you not think I think we've come a long way. I think honestly, like within the last 5 years, we were stuck in a very paternalistic society. It was just awful. I notice now, just in my own personal circumstances with my diabetes care, things like that, that decision making is a lot better. For example, I'll just give you a quick example. My son, when he was 11, he had surgery on his salivary glands to turn them backwards. It was quite a complex surgery, and this was even before my case was won. And the ENT surgeon did his consent so beautifully. He turned Sam round and he spoke to Sam face to face. He uncovered what was important to him. He wanted to go to university, so laptop, computing, dribbling is going to be different. And honestly, so I think different specialities do decision making and partnership well. But when we're talking about things like maternity care, it's a big fat from me. They do it honestly, we have a hell of a lot of work to do in maternity care, and I don't know what the solution is. I think there's a big problem with an ideology of that somehow it's morally preferable to have a vaginal birth than a cesarean section, and that's taking the the decision making away from the patients. But that's just my opinion. Sorry, I've waffled on as usual.
No, you haven't waffled at all. I think you're absolutely right that some specialties do this work really well, and some doctors do this work really well, exactly. And I think there's been huge progress. But maternity, there's a lot of improvements to be made. James, Do you have a view on the progress that's been made to date?
I do. Can everybody hear me? Can I just check and nod if you can hear me? Great. Yeah, and so it's frustrating, isn't it? Because I think for the last kind of 10 years, I've always had this sense that we're just on some kind of a tipping point and things are just about to get better. And then here, you know, another year goes by. But actually, I really, really, truly believe we are on a tipping point here. So if you look at the patient safety strategy now, there are proposals, these patient safety partners, which is all about patients engaging in patient safety. If you look at the work the healthcare safety investigation branch have done, they've modelled now much better processes for family engagement when things go wrong, and it's about now spreading that out so the whole healthcare system adopts that. So I think we've made progress, but we're just on the edge now, I think, of really pushing that forward. So, you know, we're going to have professionalised incident investigations. Trusts that do these investigations are going to have to involve the family and engage the family in a proper way. We're going to have patient safety partners working in organisations at all kinds of levels. So if all these plans happen and they're implemented well, I think we're on the verge of something that could be really transformational.
I think that's absolutely right, James, and I think we should also acknowledge that you've been quite a key influence in some of those different dimensions of the National Patient Safety Strategy in your influencing. The key thing, I think, is going to be not just how well it's implemented by trusts, but how much patients, people using services, know about those things and know what to expect.
Yeah.
And we can maybe come on to that. But Suzanne, do you have want to comment further on, you know, the progress that's been made and what more needs to be done around patient partnership?
Yeah, I mean, I agree with James to a degree. I think the HSIB are doing a good job, but I do think we have a long way to go. I think maternity care is difficult, I understand, but we have to communicate better with mothers. We absolutely have to do that, and we have to make sure that they understand the risk so they can make decisions about what they want from birth. And if things go wrong, they understand beforehand what's happened to them. And I think it will, the idea of dealing with any trauma, negligence or not, it will be so much better if patients have a complete understanding of what's involved. I can give an examples where I do think there's progress, and that's why I think that it's good for patients as well as the medical profession. I had a case where it involved potentially a man having an operation on his back. And when I got the records, there was a consent clinic record by the neurosurgeon who had separately spoken to him and explained clearly all the risks of the operation. And it was really great for me to see. Absolutely no case, sorry, apologies. There was absolutely no case because the doctor had done an excellent job of obviously consenting his patient properly. So the idea that doctors think it's a pain in the neck to, you know, the consent issue, and I've got a number of friends who are doctors, they're saying, oh my God, Suzanne, you know, this, you know, Montgomery thing. I'm like, just consent your patients. It's good for you and it's good for the patients.
Thank you. And it's good to hear that, you know, these examples of good practice, and to know that, you know, slowly but surely things are changing. Rachel, do you want to add in terms of where you think progress has been made and things that you see as positive?
Yeah, through our helpline, we do regularly see some really good examples of how patients are fully involved. But I think I'd like to reflect on what Nadine said. You know, the difference on shared decision making against supported decision making, and I think a lot of times over the last few years, and especially when I joined the organisation and was involved in a lot of external meetings, we talk an awful lot about patient-centred care and patient, and I think that shared that supported decision making, and a lot of the work that we have done is making sure that patients have, and a lot of what our members told us is that they want to be empowered to do this work, and we're about to do a piece of pilot work on shared decision making and looking to work in an integrated care system where we believe around the Yorkshire area there's ones that is doing a really good job of building really good support to shared decision making among the community, and a very diverse community. But I suppose what I'd like to do, Lucy, is it's okay, is to add a question to the panel, in that if they were the Patient Association, you know, what is our case for support when we're talking to systems and decision makers about why patient partnership is of benefit to the system?
That's a very good question. So why they should listen? So why other organisations, why the NHS should listen to us in terms of what we've got to say?
Yeah.
Okay. James, do you want to start on this one?
Yeah, I can try. I think if you look at what has been the driver for major changes in healthcare,
James, just get a bit closer to your microphone.
Oh, dear me. I think if you look at what's been the major driver of change in healthcare over the past 10 years, from major inquiry reports like MedStaff's, through to the changes Nadine has and the influence that has had on consent processes, you see that patients have been a huge driver for change. And I think the difference in the past has been that's through kind of hard-won battles. So what I would say is, let's stop the hard battles to get to the point where that change happens, and embrace it early on and welcome it, because there is huge potential, huge energy. The healthcare service exists for patients. Nobody, understands the care, the needs of care better than patients. So early engagement can have huge benefits, and I think that's very clear from just looking at the history of major change in healthcare.
I think you're absolutely right, and certainly I think most patients will say that the way, when they first raise a concern, the way they're responded to makes all the difference to getting a successful outcome. And when people are really listened to right at the start, and that their contribution are valued, and they are treated in partnership, then both they and the organisation get really positive outcomes.
Absolutely.
And it's how we change that culture to stop people being defensive and worrying about their organisational reputation the minute somebody raises a concern. There's difficulty that people seem to have with just saying, I'm sorry. Nadine.
Sorry, I was on mute. Yeah, I totally agree with that. I think that there is a huge problem with seeing, maybe because when they say I'm sorry, they feel somehow they're admitting their own liability, and they're I don't know, but if we could master that, that would be great, just in the hope that will lead to a change. That's all we're asking for, isn't it? We want a change, we want an apology, we want a change, and we want that to change so it's better for the rest of the patients. But yeah, you're right. But we have a duty of candour now, don't we?
Yeah, exactly.
Yeah. I'm not sure if we have that in Scotland. We have that in England, don't we?
Yeah, and it's not being used, and it's been a long time, and it is pretty disgraceful that it's not used when it should be. There is no excuse that there should be a duty of candour to a patient when they know that a mistake has been made and harm has been caused. I mean, patient partnership is a no-brainer as far as I'm concerned. It's going to make, it's going to give better treatment, it's going to be better outcomes, it's going to help resources, because I think mistakes aren't going to happen as much, and also patients will be managed much better when things do go wrong. And on top of that, we're going to have happier patients, and we're going to have happier medical staff, because it impacts on both sides. I see the trauma that it happens to the families, but it's important, and it improves everything if there is a patient partnership. I think it's disappointing that we're still talking about it. I read a blog very recently, it's a pharmacologist actually, who'd I think her child had died or been injured, and she was so upset with the way that she was treated as a medical professional, because she just never got an apology, there was no duty of candour, and she just felt that everyone was protecting their professional position, whether the GMC or the NMC. So these things have got to stop, and we've got to be more progressive about this and think holistically and work together, I think.